The recent shootings in Orlando highlight a problem that has been growing in our country. Whether we're talking about Orlando or Aurora or the Boston Marathon, we have realized the need to be prepared to receive large numbers of victims who suffer from penetrating trauma. This creates a burden on emergency departments as they struggle to plan with how best to respond.
I think it's important to realize that this involves more than just emergency responders, whether they be in the field, in the emergency department, or in the trauma unit. Every hospital has got to have a plan that not only involves the emergency department, but involves rapidly decompressing both the emergency department and the operating rooms of non-emergency procedures, moving those patients to other areas of the hospital so that we can open up potentially every OR and every ER or emergency department room. I think another sobering fact is the fact that our views on tourniquets have changed so dramatically. Not that many years ago, tourniquets were contraindicated. They cause vascular injuries. They cause nerve injuries. What we now know from the battlefield, what the military has taught us, is tourniquets save lives and they save limbs. And after Boston, I think many of us now appreciate the fact that tourniquets are important in civilian responses. And so I think more and more physicians, more and more nurses, more and more of the public ought to consider carrying a tourniquet. They're very cheap, either in your car or at home, or sometimes, depending on what you're doing, even on your body. We've got to have more than just surgeons, emergency physicians, emergency nurses, and EMS personnel know how to use tourniquets. I think every healthcare provider should learn how to put on a tourniquet and learn how to control exsanguinating hemorrhage. All of us now need to be more prepared than before this event. All hospital systems need to be doubly sure that their call-out system works well and is infallible. Because as we just saw, things can happen at 1 or 2 in the morning when most people are at home in bed. We've got to be able to mobilize the entire hospital, not just the emergency department and operating room, but all those who support both the emergency room, the operating room, the inpatient areas, radiology, the lab, the blood bank, all the administrators, all the people that get beds ready, all the people to move patients. This is something that the entire hospital has to be ready for.
I think that people need to look at their OR capacity and, if they're planning ahead for mass penetrating trauma. The use of tourniquets has been mentioned. Great idea. We have them up on the wall in our trauma bay. We're actually, one of our docs has gone into the community with a lot of the nurses and resident docs and teaching the community how to apply tourniquets. And that's going on in a couple of different places across the country. So I think that'll be a change. I think that's, people need to really look at that. Could we get a mass shooting in here? And they'll really just have to decide whether they're going to be able to access the OR fast enough. But then again, a lot of victims of shooting, it's, if it's extremity trauma, that doesn't have to go necessarily to the operating room right away and can be managed within the emergency department. We're overcrowded. And when a disaster happens, we already have a full emergency department. So that has to be looked at beyond the local level, the federal level, state level, keeping the trauma centers open. We're in desperate need of an expansion. Where's the funding for that? It's got to come out of the hospital bottom line. People, if they're interested in trauma, improving trauma care, they have to pay attention to the lack of resources that a lot of the big academic medical centers have in keeping their EDs open for these kind of situations. There's national solutions that need to be enacted. I think for each individual hospital, they're going to have to say, wait a second, we could get some penetrating trauma and just brush up on it, make sure they're able to open up a bunch of ORs quick. If they haven't seen penetrating trauma, go over the drills of things like, do you have enough chest tubes? Can you do an ED thoracotomy? Do you have that? Place like Temple, not a problem. Do it all the time. But again, not too many places are regularly seeing penetrating trauma like we are in some of the other centers in the big cities.
The American College of Emergency Physicians has for many years had a group of physicians formed into a section referred to as the Tactical Emergency Medical Section. These physicians have dedicated themselves to providing care to law enforcement and other first responders who provide care in the tactical environment. This includes SWAT teams, warrant entry teams, Border Patrol, and the like. However, recent events have forced the college to look at how every emergency department, not just those involved with law enforcement, respond to active shooter and other incidents where multiple victims of penetrating trauma may present. In response to this, ASAP's President Jay Kaplan put together the High Threat Task Force. The idea is that the college can leverage the knowledge of its members, those in the EMS sections, those in disaster medicine, those within the tactical emergency medical section, and others, to work together to really have a cohesive focus on how we as a college can address the needs of our members in terms of providing them some guidance when the unthinkable happens.